Hi, everyone. Thanks for being here today. I'm Jen Hanson, and I'm joined by Jenny Lorca, and we're delighted to be able to talk to you today.
Hi, everyone. I'm Dr. Jennifer Stinson. I'm a nurse clinician scientist at the Hospital for Sick Children, and I'll be moderating this session entitled Self-Management and Coping Strategies in Isolation, Online Service Delivery, which is sponsored by GAPA and the International Association for the Study of Pain. So I'm going to introduce the four speakers today. Jen Hanson is the Director of Education at Pain BC. Pain BC is a registered charity comprised of people in pain, clinicians, researchers, and other supporters with the mission of improving the lives of people with pain through empowerment, education, and innovation. In her role, Jen leads Pain BC's education initiatives and oversees the organization's work to catalyze change and build capacity among patients and healthcare providers across the province of British Columbia in Canada. She has driven the development of many of the organization's innovative programs and resources, including online self-management resources, Live Plan B, and mycarepath.ca, Pain Foundations, an online course for healthcare professionals, Coaching for Health, an individual phone coaching program, and Making Sense of Pain, a self-management class series designed for people experiencing marginalization. Jen's background is post-secondary education, professional training, and program development. She'll be talking on a pandemic pivot, adapting Pain BC's supported self-management programs for people in pain. Our next speaker is Jennifer Lorca. She's a nurse and a holistic health practitioner, a former theater arts and somatic therapist with the Center for Mindfulness-Based Somatic Therapy. She's dedicated to working alongside individuals and families on their health and wellness continuum. As a health professional and a person living with pain and complex chronic disease, Jenny has accessed Pain BC's services, resources, and education at multiple levels and with multiple lenses. She's also a volunteer with Pain BC in Coaching for Health and pain support and wellness groups programs, and she'll be talking about her lived experience. Our next speaker is Dr. Rachel Coakley. Rachel is a pediatric pain psychologist in the Department of Anesthesia and Clinical Care and Pain Medicine at Boston Children's Hospital, where she serves as the Director of Clinical Innovation and Outreach in Pain Medicine and the Associate Director of Psychological Services. Additionally, she is the founder and director of the Comfortability Program, which is an internationally distinguished program that teaches evidence-based pain management skills to adolescents with chronic pain and their families. Dr. Coakley is an assistant professor of psychology at Harvard Medical School and holds many national and international leadership positions. She completed her undergraduate work at the University of Pennsylvania and her doctor's studies at Loyola University in Chicago. She completed her fellowship at Boston Children's Hospital and then joined the Pain Treatment Service in 2006. Her career focuses on translational research of evidence-based psychological interventions for pediatric chronic pain management. For her work in program development and enhancing access to clinical care for patients with chronic pain, she was honored with the 2016 David Weiner Award for Leadership and Innovation in Child Health with the American Psychological Association's Carol Schuber 2020 Award for Outstanding Clinical Practice. Outside her work in program development, Dr. Coakley enjoys writing and lecturing to educate parents about and providers about chronic pain. Her 2016 book, When Your Child Hurts, Effective Strategies to Increase Comfort, Reduce Stress, and Break the Cycle of Pain, Yale University Press, won the National Book Award for Best Parenting Book. And her writing has also been featured in Psychology Today and the Washington Post. Dr. Coakley is going to be talking about mobilizing evidence-based online treatment during the COVID-19 pandemic, the development and deployment of the virtual comfortability program for pediatric chronic pain. And our final speaker is Dr. Romy Parker. She is the professor and director of pain management unit in the Department of Anesthesia and Perioperative Medicine at the University of Cape Town. She is an active researcher who has successfully supervised numerous postgraduate students. She is also the course convener of the Postgraduate Diploma in Interprofessional Pain Management, the first program of its kind in Africa. She is an expert physical therapy clinician working in chronic pain as part of the chronic pain management interdisciplinary team at the Rutshire Hospital. Her research focuses on pain, with an emphasis on developing and testing mechanisms-based treatments relevant to the South African context. She serves as a counselor for the International Association of Study of Pain. She is the current past president of the South African chapter of IASP, the past chair of Pain Mind Movement Special Interest Group of IASP, and an honorary life member of the Pain Management Physiotherapy Group of South Africa Society of Physiotherapy. She was awarded the UCT Distinguished Teacher Award in 2019, the university's highest honor for teaching. Since the start of the pandemic, her clinical and research work has focused on effective ways to continue treating people with pain in this environment and on the rehabilitation of people suffering from long COVID. She'll be talking on converting pain education empowerment programs, or PEEP, to ePEEP. So I hope you'll enjoy this session. Thank you.
Hi, everyone. Thanks for being here today. I'm Jen Hanson, and I'm joined by Jenny Lorca. And we're delighted to be able to talk to you today about our presentation, which is called A Pandemic Pivot, Adapting Pain BC's Supported Self-Management Programs for People Living with Pain. So before we begin, I'd just like to acknowledge that we work and live on the traditional unceded and ancestral territories of the Coast Salish peoples in Canada. This includes the Stolo, the Kwantlen, the Simiamu, Tsawwassen, Tsleil-Waututh, Squamish, and Musqueam nations. And we're very grateful to be able to use this land. Disclosures. So I am an employee of Pain BC. We're going to be talking today about Pain BC programs. Jenny is a volunteer and contractor at Pain BC, and many of Pain BC's programs and initiatives are funded in whole or in part by the government of British Columbia. Our objectives today is we're hoping to tell you a little bit about the experiences of people in pain using virtual self-management services during COVID. We're hoping that you can understand the adaptations and processes for moving face-to-face programming online. And we're going to talk a little bit about the differences in online versus e-service, or in-person service delivery. Jenny.
So, hi, thank you, Jen. My name is Jenny Lorca. I am a registered nurse specializing in hospice palliative care. I live in Surrey, British Columbia, Canada. I'm also a somatic therapist with the Center for Mindfulness-Based Somatic Therapy, a counselor in training, and a volunteer with Pain BC in multiple programs. So this picture here is me as a shiny new nursing grad. Prior to nursing school, I was a hospice care aide, and so working with people at the end of their lives, people living with acute, chronic, persistent, complex pain and other symptoms had been a long time passion for me going into nursing school because I knew where I wanted to go. My relationship with Pain BC actually started in nursing school as part of my continuing education, because I first accessed their resources as a student and then as a family member of a person living with chronic pain. So going into nursing school, I was grateful that I knew what I wanted to do. I had passion and a clear direction working with the end-of-life community, and I thought that palliative care nursing was it for me. Next slide, please. In 2019, however, I was diagnosed with rheumatoid arthritis, fibromyalgia, and chronic fatigue syndrome, all of which effectively cut my nursing career short. I no longer had, nor do I still have, the capacity to maintain any sort of regular work hours, regardless of rest, rehabilitation, or return to work programs. And so, like this image, I felt broken, alone, isolated, betrayed and abandoned by my body, and useless. So it was then that I accessed Pain BC services as a community member. Next slide, please. So, as a person living with pain, I attended their in-person pain support and wellness groups, which are peer facilitated. While at the same time needing to be in service or of service, I trained to be a volunteer health coach with their Coaching for Health program, and then later as a facilitator with the pain support and wellness groups. There's nothing like finding a place where you belong, where you know that when someone says, I understand where you're coming from, that they actually get it. And then that in my cracked and broken state, I found myself among people who were like me. I can honestly say that I took attending the pain support and wellness groups as seriously as I did any one of my prescriptions or tests or treatments, because being part of this community was as essential for me for my physical, emotional, spiritual, psychosocial well-being as any intervention. So at this point, I would like to invite my co-presenter, Jen Hanson, to introduce herself and talk about how Pain BC embodies its commitment and dedication to the community.
Thanks, Jenny. So yes, I'm Jen Hanson. I live in Vancouver, BC, and I'm the Director of Innovation at Pain BC. I've worked at the organization for about 6.5 years. Formerly, I was the Director of Education. And in that capacity, I oversaw the development and deployment of Pain BC's educational offerings for healthcare providers and the self-management programs and resources for people living with pain. And I'm also the daughter and sister of people who live with pain. And so the work has a very important personal side to me. I thought I would just share with you a little bit about the organization, because I'm not sure how much people know about it. We're a charity, first and foremost, and it's a charity dedicated to improving the lives of people living with chronic pain. We're based in the province of British Columbia, but are slowly expanding our reach nationally, and then we hope we can provide resources internationally as well. Our vision is a future where no one is alone with pain, and our mission is to enhance the well-being of all people living with pain through empowerment, care, education, and innovation. Everything we do is guided by people who live with pain. The organization was founded via partnership between healthcare providers and people living with pain, and that approach is still reflected in everything we do today. And finally, we do our work via a collective impact model, which means that although we're a very small organization, we have a very cherished army of collaborators that we work closely with, and together we can really strengthen and amplify all of that work. So very quickly, our work is really centered on 6 strategic areas: prevention and early intervention, research, combating stigma and its negative effects, education for healthcare providers, system improvement, and then what we're going to talk about today, which is empowering people with pain to enhance their well-being. So I'm just showing you here a continuum of self-management programs that we offer to people in pain, and really we're going to focus today on the programs that are on the right side of your screen: gentle movement at home, pain support and wellness groups, coaching, and making sense of pain. So I'm first going to tell you about gentle movement at home. So gentle movement is a training program that instructs therapeutic movement professionals to deliver a 5-week gentle movement and relaxation program for people with chronic pain. When the pandemic hit and we were in lockdown, people obviously lost access to their physiotherapists, to their gyms, to their swimming pools, their yoga instructors, their massage therapists. All of those therapeutic modalities they use to manage their pain. And we really heard from them that they were really feeling that, and that function was very quickly declining, and that the isolation was really having an impact. So in response to this, we very quickly put together a program where we started running free online movement classes 2 to 3 times a week. And these were led by physiotherapists, OTs, and other therapeutic movement professionals. The focus was really on creating a sense of safety for people through movement, or a sense of safety to move, and then enhancing that sense of safety by trying gentle movements and relaxing stretches. We ran the program for 3 months, and we ended up with a library of 37 classes, which are still available online, and you can see the URL at the bottom of the screen. And by the end of 2020, we had about 30,000 views. This was the first programming adaptation we did during COVID, and our takeaways were, one is we had to move really fast to get services into place. Did not have to be perfect, it just had to exist. 2, we learned not to be perfectionists. We used whatever tools we had. We were already familiar with Zoom, and we were using it. So we helped our instructors learn how to use it as well. They used their mobile phones to record themselves. They pushed aside the furniture in their living rooms. They created spaces in the corner of their offices and in the middle of their days, and they just ran this program for us, and we were so grateful. We prioritized accessibility, so we tried to schedule it when we thought people's energy levels would be good and that they could attend. We recorded it. Of course, we didn't charge, and we just really tried to create a welcoming environment where folks would be willing to try and willing to come back. And I think the 4th thing is, as the lockdown hit, we were all really grappling with what it meant to be living in a pandemic. And we wanted to pay attention, and we had to pay attention to our own emotional states, the needs of our instructors' emotional states, and the needs of our participants. And, what we saw from our instructors is they are at the heart service professionals and really wanting to do something to positive in the pandemic. So that was really interesting. They were just so keen to offer some kind of support, because otherwise I think they were feeling pretty helpless. So that was really neat to observe. Okay. I'm moving on to the second program that we have. This is our pain support and wellness groups. Pre-COVID, Pain BC ran 11 in-person peer support and wellness groups. These groups are led by a trained peer and provide a structured time for education, support, and social connection. During lockdown, they were moved online, and we had to move very quickly to help facilitators become comfortable using the technology. They had to learn how to create the same feeling of community and connection online that they had done so well in person. And we had, in the office, we had to create a registration system to manage group size, and we had to figure out all the privacy and confidentiality pieces and ensure that those were maintained and that we could keep participants' trust and safety top of mind. Jenny, over to you.
Thank you, Jen. I just have to quickly say that I deeply appreciated being able to access the Gentle Movement at Home series, and I'm grateful to everyone from the movement therapists to the entire team at Pain BC that they were able to create this and provide this alternative service so quickly. So one of the most precious commodities people living with pain have is energy. And when you live with pain or any complex chronic condition, you become acutely aware of what tasks or activities of daily living you have to complete and where your energy needs to go. So when Pain BC shifted their pain support and wellness groups from an in-person to an online platform, they effectively created the space, not only for us to safely and meaningfully connect with a community in isolation, but it enabled us to guard and conserve those precious parcels of energy. So you can imagine what that opened up for us. Instead of efforting to get ready, to leave the house, to commute to group, to attend group, to commute home, to decompress from group, we could actually allocate that energy to and time to other also meaningful things like sharing a meal with a family, or doing the dishes, or resting. Uh, Another example of this pivot from in-person to online is our group comfort agreement for the pain support and wellness groups. And unlike many online groups or courses that I've been to, we invited people to participate in whatever way they felt comfortable and safe with. They could leave their cameras on or off. We encouraged their physical comfort by inviting them to sit, stand, move, lie down, however and whenever they needed. And if there was something particularly emotionally activating for an individual, one of our facilitators could take them into a breakout room to be with them until they were ready to rejoin the group. So, in essence, we facilitated a safe physical and emotional environment that allowed us to truly meet people where they were at so that they could conserve their energy, tune into their own needs, and connect with people who understood where they were coming from in meaningful ways. Go ahead, Jen.
Thanks, Jenny. All right, the third program I'll tell you about is Coaching for Health. So Coaching for Health is a Pain BC run program. It's a free one-to-one phone coaching service that offered to people in pain for 6 to 12 weeks. Coaches are highly trained volunteers who listen and work with their clients, and they've been carefully paired. So we really work hard on matching people we think are going to get along, and the coaches can really help. So coaches meet clients where they're at, and they might help them learn about self-management. They might help them create some kind of self-awareness and really start to take steps towards their well-being, whatever those steps are. The program's format didn't change during COVID since it was already a phone program. Instead, we saw changes in the types of people who access the service and their reasons for doing so. And Jenny's going to tell you about one of her clients.
Thank you, Jen. So as Jen described earlier, most, if not all, of the in-person services that people use to manage their pain were shut down, thus leaving people relatively stranded without any means of comfort or pain management, which meant that we saw a newer influx of people living with pain, people who wouldn't ordinarily reach out to Pain BC services, such as the one-to-one Coaching for Health program. So I just want to share one of my experiences as a coach with the Coaching for Health program. During COVID, one person I connected with was a 90-year-old gentleman who lived with chronic persistent pain for 30 years, pain that he rated 7 to 9 out of 10 on a regular basis. That's severe pain. He and his wife lived independently in a smaller central British Columbia community, and so the lockdown compounded his sense of isolation and helplessness. And because the services were shut down, he reached out to Pain BC as a last resort. He never would have considered it otherwise. However, through our work together, we discovered a mindfulness practice that he found actually helped him consistently reduce his rating of pain from severe to mild to moderate. And that's significant. And near the end of our coaching relationship, the client expressed that his whole experience was nothing short of miraculous, because if the COVID shutdown hadn't driven him to give Pain BC a try as a last resort, he would never have connected with me, nor discovered a personal practice that was consistently and highly effective in managing his pain. So how empowering is that? As Jen described, he's not the only community member who found themselves reaching out to Pain BC during the pandemic. So I'll turn it over to Jen, who'll talk about the next program, Making Sense of Pain.
Thanks, Jenny. So this is the last program I'll tell you about today. Making Sense of Pain is an 8-week self-management program for people experiencing marginalization. These folks generally have extraordinary difficulty accessing any kind of pain care due to issues like substance use, mental health, poverty, trauma, violence, and food and housing insecurity. They generally have had pretty bad experiences with the healthcare system. we run this program in person, and we've been slowly, what we do is we train local healthcare providers to facilitate the group. And we sort of provide administrative support, we provide all the curriculum resources, and we provide some seed funding for the group as well. So the program's facilitated by a healthcare provider with experience in mental health. The program itself takes a trauma and violence informed approach to self-management. It includes topics like pain neuroscience, stress, mood, thoughts, feelings, grief, and loss, as well as communication, movement, pacing, nutrition, and sleep. And it provides really, I think, some of the real success of the program is that it provides a judgment-free, supportive environment in which participants are always welcome, no matter where they're at. It is safe. Their lived experience is shared, and it's really viewed as a strength. We provide food along with the transportation subsidy. So we were in the process of spreading this program to as many communities as we could when the pandemic shut it all down. And we kind of hesitated offering it online because we weren't sure about a lot of things. I mean, one of the value of the program was that we provided this really safe, welcoming space. We provided a meal, and we were really unsure about putting it online because we didn't know if participants had access to the technology that they would need, as well as an internet connection. So we thought we would start off with a small pilot. We would take referrals from clinics that knew us, who had already run this program before, and they could just give us a few of their people on the wait list. We used a facilitator who had facilitated this program before in person, who was familiar with our organization and very familiar with the curriculum. So we worked with her to redesign the program for online. So first thing we did was we reduced the amount of time that the meetings were, so from 2 hours to an hour and a half. We extended the number of weeks for the program from 8 to, actually it was 12, and then it had a 2-week break in between so folks could practice what they had learned. We also created a more structured participant material. So we mailed a workbook with notes to each person, and then we developed a referral and intake process, which included a lot of introduction and care and a technical introduction for participants. So this was the onboarding process, and it was very individualized. And our administrators maintained contact with participants throughout the program. So we called them, we made sure they knew how to use the technology, we made sure they knew how to access the link. If they didn't show up, we called them, we did some technical troubleshooting with them. I think that was very key to the program's success. And then other times if they didn't show up, we also just called to see how they were. We made sure they knew they were valued and that they were missed in the group. As a result, we saw that people were really committed to the class. We didn't have very much attrition. People found support in each other, and in the facilitator, the online format did allow that. And people made extraordinary efforts to attend. One of our people, he drove 20 minutes to get a cell signal so that he could join the class. So we're in the process of now creating another online offering this October. Jenny.
Since my diagnoses, I've had to let go of many of the roles associated with my identity and the expectations I had about my future to live with what I called my shining new normal, which is a person living with pain and complex chronic disease. This is an ongoing process of grief and loss, of acceptance and restoration, and I could not have done it without connecting to a community that offers the kind of resources that empower me to do so. Next slide, please, Jen. I've often been comforted by Rumi's quote, "The wound is the place where the light enters you." It also reminds me of that line in Leonard Cohen's song, Anthem, which goes, "There is a crack in everything. That's how the light gets in." One of the metaphors that gives me comfort is that of Kansugi, which you'll see on this screen. Kansugi is the Japanese art of repairing cracked or broken pottery with gold or other precious metals. I found this metaphor so poignant because that in embracing flaws and imperfections, in highlighting the scars as part of the design, you can create an even stronger, more beautiful piece of art. That in the process of repairing things that have broken can actually create something more unique, beautiful, and resilient. So the programs that Pain BC provides offers us the chance to see ourselves not as broken or even needing repair, but as beautifully, painfully, poignantly imperfect people.
And just from a systems perspective, this is a slightly different interpretation of this metaphor, but COVID really exposed the cracks in the system, and we saw that disproportionate impact that COVID had on people living with pain. But in doing so, it really allowed us to better see those gaps and to rebuild some of what we could to do better, and to make our programs more accessible, and to really, I hope, really suit people living with pain just a little bit better.
I would also like to say this one last thing about COVID and my experience living through it. I can speak for many of my chronic pain and chronic illness community members in that COVID didn't change much in how we interacted with our environment. We were already isolated, frustrated, powerless. We already experienced struggles with accessing in-person services and with meeting the demands of our day-to-day life. However, it wasn't until this pandemic impacted the global community that we, in our collective isolation, as Jen has been illustrating, sought new and innovative ways of communicating and connecting. And so those within my personal sphere found that they had some small understanding about the challenges that people living with chronic pain and chronic illness face on a daily basis. So I hope that this whole series about pivoting during pandemic times can helps illuminate how partnership with communities can enrich our understanding and teach us new ways of being in the world together.
Thanks, everyone.
Hello, my name is Romy Parker, and I'm going to be sharing with you today on how we set about converting our pain education empowerment program to a virtual EPEEP program. So I don't work on my own. These are my wonderful colleagues that I work with here at the University of Cape Town and at our neighboring university, the University of Stellenbosch. And as you can see, we have wonderful multidisciplinary teams at these two universities and the hospitals that we work in, including physiotherapists, paramedics, psychologists, anesthetists, and psychiatrists. And we work at these two hospitals, Tygerberg Hospital and Groote Hospital. These are tertiary academic hospitals associated with the universities. And we're in Cape Town, way down here at the bottom tip of Africa, where right now we're getting hit with the end of winter. We're looking forward to a change in season soon. Now, we are very privileged to work in these sophisticated tertiary academic hospitals in multidisciplinary teams with a lot of support and contact with the rest of the world. Our patients are not so privileged. Our patients live in communities like these here in Cape Town. The image on the left of your screen, a typical informal settlement where residents may be lucky enough to have electricity, but they certainly do not have running water or sewage. And they live in informal shacks, really, primarily built of corrugated iron or tin. And many of our other patients live in high density, low resource suburbs, such as the one illustrated on the right. The typical patient who comes to our chronic pain management clinics at these two hospitals is in their 50s and predominantly, most likely, a woman. Majority of our patients have not completed schooling, with some only having a primary school education and some never having had the opportunity to attend school. And perhaps not surprising for those of you from developing countries, but perhaps surprising for many of you, is that less than a quarter of our patients are actually employed. Now, one of the key strategies that we use in our chronic pain management clinics at these two hospitals is the Pain Education Empowerment Program, PEEP. This is a 6-week exercise and education program that is delivered once a week, with patients attending the clinic for 2 hours at a time for a group education and exercise class that uses problem solving and goal setting with the aim of empowering our patients and improving their pain self-efficacy. And our work over the years on PEEP and modified versions of PEEP for people with osteoarthritis or with pain associated with HIV have shown that we make significant improvements in patients' pain interference with function primarily. Now, unfortunately, COVID hit South Africa and we went into a hard lockdown situation in April 2020. This meant that our outpatient services were halted, that many of our clinical staff were diverted to work in acute COVID settings, and our patients were restricted to being at home, only being allowed out to buy essential foods. Everybody was stuck at home, and many people stuck at home alone. For us as chronic pain clinicians, this was really concerning. And so we put our heads together as a team in a virtual meeting as we were learning how to negotiate this virtual environment, and started discussing how we might continue to provide treatment for our patients who are suffering with chronic pain. And we started discussing whether we could deliver our PEEP program in a virtual environment. Is this feasible given the resources and the settings that we're in? The first question we asked ourselves was, do we actually have the capacity to run these groups virtually? Did we have members of our team available who had time to give to this? The second question we asked was whether we had the resources to run groups virtually. We were all fairly naive at that stage about tech and materials and developing online resources, and how do you do this with a cell phone, never mind a computer? And did we have access to internet? Would we have access to data to be able to do this? And then the question of whether our patients would have the resources to be able to participate in a virtual group. Would they have smartphones? Would they have computers? Would they have access to data and internet? And perhaps the final most important question was, would our patients even be interested in participating in a virtual group when the world was struggling with a pandemic? We decided to move forward step by step, and we started with laying some foundations. Our first question was, what platform could we use to run virtual groups? We decided to use WhatsApp as our platform because it's widely used in South Africa. It has end-to-end encryption. And at that time, it had recently expanded so that we could have group video calls with 8 people. That potentially meant that we could run a group with 7 patients and a facilitator. And as I said, WhatsApp is widely used in South Africa, so we felt that it would be familiar for many of our patients. We managed to source 2 smart cell phones and get dedicated phone numbers so that we could use those for the group, and that members of the clinical team wouldn't have to use their personal phone numbers to facilitate the groups. We managed to source a little bit of funding. We used that funding to send data to patients each week and to courier the printed workbooks to patients so that they had some resources to guide them through this process. Within our team, we had facilitators who were familiar with running PEEP face-to-face and who were available and able to work in English and Afrikaans, the 2 languages that our patients most commonly speak. We laid some foundations in terms of setting a code of conduct for working and engaging with patients in the setting. And then we set about the next step on this project, which was to develop materials for use in this virtual setting. To develop the materials, we started off by analyzing the Peep curriculum, and we recognized that really over the years of delivering Peep, the program has grown and morphed, and each clinician who's facilitated the program has added a little bit to it. And so it has got bigger and more detailed. We realized that delivering it in this setting, we needed to pare it down to its essentials again. And so we considered the essential educational messages within the curriculum, and we considered education in terms of information giving, which was different from education and activities that we considered important for experiential learning. And then we considered what tasks and goal setting activities we needed to keep and emphasize in the program to ensure skill acquisition with the objective really of increasing our patients' self-efficacy in managing their pain. The structure of the Peep program follows 6 weeks with distinct topics for each week of engagement. The first week focuses on the principles of self-management and explaining pain. The second week, looking at the role of exercise as an active pain management strategy. The third week focuses on the terrible twins of stress and pain. The fourth week on healthy eating. The fifth on wise use of medication to empower our patients to use their medication appropriately. And the final week of the program focuses on recapping and reminding patients about the tools that they've acquired in this learning experience and how they can focus on continuing as self-managers. One of the things that was clear to us as clinicians who've been involved in delivering Peep face-to-face for several years now is that group cohesion in the delivery of this program is really critical. And so we gave quite a lot of thought to how to initiate the groups in this virtual environment using voice note messages to introduce ourselves, to facilitate a safe and cohesive environment where patients felt that they could be heard and that it was a safe space to participate in. In terms of information giving, educational, if you like, didactic information, we thought about delivering this in a front-loading strategy at the beginning of each week. And so we developed materials such as short text messages, which would be sent to the participants in their WhatsApp group on a Monday. We also recorded short podcasts on the education topics for the week, aiming for each of these to be less than 6 minutes in length. And some of my team members even went so far as to develop short videos to demonstrate things such as role play in goal setting and how to set SMART goals. We also shared internet-based resources such as the resource from Royal Holloway University of London developed by Professor Tamar Pincus on pain and me. And we collaborated with Professor Pincus and her team so that we were able to put Afrikaans subtitles onto this video resource to make it more accessible to our patients. We then split the curriculum up so that we had the front-loaded didactic information giving, which then linked with the engaged learning, the group activity, which took place in a facilitated group video call on the WhatsApp platform once a week for 1 hour with the facilitator. The goal of this group activity was to discuss the educational topic of the week and to personalize it, to allow for social learning and to get patients to engage in active learning strategies. So not only did they get to discuss things on this video call, but they were also all prompted to prop their cell phones up where they could see them and engage in an active exercise class together of at least 20 minutes. They also all engaged in goal-setting exercises on a weekly basis. The engaged learning was then followed up with backloading, and this took place on a Friday, with the facilitator posting materials to patients in the WhatsApp group to prompt further reflection or to embed knowledge or to get them to engage with more materials. This backloaded material included podcasts that an expert patient, a graduate of the Peep program, recorded for us, reflecting on how she has used the knowledge and the skills that she acquired through Peep in managing her chronic pain conditions since that time. We also had recordings and videos of different physical exercises and mindfulness activities that patients could experiment with, or sometimes we provided links to web resources or videos, and we really encouraged the patients to watch these with friends or family. So how did it all go? Well, we set up all of that groundwork. We had a look at how many patients had been referred to us for the Peep program up to that time. And we had 51 patients on our waiting list. We set about contacting them by telephone, and we managed to reach 27 patients. And of those 27, 19 were interested in participating, and perhaps more importantly in this situation, had smart cell phones to enable their participation. Of those 19, we were able to place 7 into a group that would be facilitated in English, another 7 into a group facilitated in Afrikaans. Those 2 groups ran with 4 patients graduating from the English group and 3 graduating from the Afrikaans group. We lost a few patients along the way, but some patients had taken a passive role in participating in these groups, saying that they didn't feel comfortable, they were nervous of the environment, and that they acknowledged that they were really just there as observers. And these 3 patients who had been observers of these 2 groups then joined a 3rd group, which was run as a bilingual English, Afrikaans, Gemenyo Tale, mix it all up group, as often happens in South Africa, which ran subsequently. And those 4 patients who formed that mixed language group all graduated. If we look at that, we had recruited 18 people to participate in total, with 11 graduating, a 60% completion rate, which is similar to the completion rate from our face-to-face programs. The patients who participated in the group were all women. One man was invited, but was lost to follow up. They were in their 40s, and the majority had no internet access at home, and so were reliant on the data that we purchased and sent to them to be able to take part. They were suffering from a range of chronic pain conditions, but chronic pain conditions that are all pretty typical in presenting to our chronic pain clinics at our 2 hospitals. So we then set about evaluating the feasibility of delivering ePeep in a longer term. We performed weekly debriefing of the facilitators to identify barriers and facilitators to delivering the program. And we wanted to explore patient acceptability. And so we conducted interviews with patients who had completed the program via a WhatsApp call, a minimum of 2 weeks after completing their course. And these WhatsApp call interviews were conducted by a member of our team who had not been directly involved in delivering the program. Engaging with the facilitators, asking the question of whether we had the capacity to run the groups virtually. Well, certainly in terms of people skills within our team, we were able to use our clinical skills in the virtual setting and manage that environment. But feasibility in terms of time is another question, because clinically, when we run Peep face-to-face, it takes 18 hours of clinician time. But in this virtual setting, we found that it was taking 28 hours. Over the intervention period, not only did it take clinicians time to manage the face-to-face video calls, but a lot of time was needed for front-loading, back-loading, sending participants data, and dealing with group communication in the WhatsApp groups. Did we have the resources to run the groups virtually? In terms of materials, we certainly seem to have developed these using the available resources, and these were appropriate and adequate. We had the technology, but funding may be an issue in terms of long-term sustainability in delivering this program. While we found funding to do this as a stopgap emergency treatment, we're not sure whether funding will be available to us in the long term. So what did the patients think? As I said, we had several graduates, and we approached all of them to participate in the study of how to give us feedback on what they had thought of it. So when we asked our patients about their experience, they reflected that they had been on a journey of discovery, a journey which had a very clear departure point, many of them describing a life of misery. All you know is you're in a hell of a lot of pain. Patients reflecting on how they had lost sight of themselves, lost sight of their goals and their experiences and their ambitions. And so they came together on this journey of discovery and engaged in meaningful learning. And as we discussed with them the meaningful learning, they were able to identify some clear components that contributed to their ability to learn in this environment. The first was that the group was non-judgmental. It gave us a platform. It gave us a platform to be heard. The second component that was critically important to contributing to meaningful learning was the active engagement with learning. I don't think that I would have realized what major impact physical activity has on your body and your life until you start to become physical. This from a patient who found that the physical activity didn't also just reduce her pain, but also helped with her depression. And then the shared experience of embarking on a journey with others who understand seemed to be critically important to this learning. It seemed to help that we can relate to each other. It's nice to talk to someone that has the same problems that you are having. And the sad reflection that sometimes you speak to the doctor, they don't really understand. And so engagement in meaningful learning led them on this journey of discovery to the destination, to a transformed identity. I'm looking forward to life. I am alive. I am alive. I'm not just existing anymore. I am a person. And that this transformed identity was linked to a changed mindset. My world changed. My way of thinking changed. My way of doing things has changed. So our patients engaged in a journey of discovery, transforming their lives. And we asked them, as they had found the program beneficial, were there any recommendations that they would make to enhance the program in future? They all felt that more time was needed. 6 weeks was not enough, that it felt too busy and crowded initially, and that at least 7 weeks was required. Patients also reflected that for some people, this platform was really quite challenging, and that they may need some coaching to enable them to use the platform and participate in the group right from the beginning. And finally, they all wanted some face-to-face contact at some point in time, and that a follow-up would be helpful. So, do we have the skills and knowledge to be able to develop and deliver a virtual pain education empowerment program? It does seem that way. Do we, in this resource-poor developing country of South Africa, have the resources to be able to do this? Well, we've managed to do it so far. Is this sustainable? Maybe. We do need ongoing financial input to this program to be able to buy our patients' data and to be able to print and send them the workbooks. Ultimately, the question of whether it's possible to run a virtual chronic pain management group in a low resource setting like ours, that's been answered. Of course it's possible. And perhaps the most important question, do our patients benefit from this intervention? And I think our patients' comments answer that. You must understand that that group changed everything. So I hope that by sharing our journey of discovery with you, that you have learned something about how to adapt a face-to-face program for delivery in a virtual setting when you do not have resources at your fingertips. And that you might be able to apply some of this to make a difference for people living with pain where you are. So thank you for spending time with me, and I hope we have a few minutes to discuss and answer questions.
Hi, I'm Rachel Coakley, and I'm the founder and director of the Comfortability Program and the director of clinical innovation and outreach at Boston Children's Hospital. And I'm thrilled to be here to be able to talk with you all a little bit about what we've done with the Comfortability Program in the face of COVID-19, how we've revamped things, and where we are with our program right now. So let me go ahead and jump in. First, just a couple of disclosures. I'm going to be talking, of course, about the Comfortability Program. And this is a chronic pain intervention. It's licensed through Boston Children's Hospital. We have 25 other children's hospitals that are partners in this program. And just to say that there are licensing and training fees that are part of this program, and that comes back to fuel the work that we do, the lab and the salaries for the people that work on this program. In addition, I also receive royalties from a book I've written on the same topic about helping children with chronic pain. First, a couple quick acknowledgements. So I don't save these to the end because although I am delighted to be able to be the presenter today, this body of work is a team effort, and so many people have been involved. So a quick shout out to Dr. Simona Bujaranu and Dr. Amy Hale, who are my clinical psychology partners on this project. Simona is the associate director of the Comfortability, and Amy is our clinical lead. And my team as well, Janae Biggs, who is our program manager, Dr. Carolino Donato, who is our bioinformatician, and Dr. Bobby Riley, who serves as our medical consultant as well on the project. In addition to that, this program is supported by a really robust peer advisory board, some teens and young adults that help to inform this work that we do, and a parent advisory board. And they really keep us grounded, provide a lot of boots on the ground information and inspiration to guide the work that we do. We're also, of course, have a lot of support from our Department of Anesthesia and from all of our organizational partners and partner hospitals in this program as well. So huge shout out to everyone who has touched this project, because this is a big body of work at this point in time. Okay, just to keep everybody grounded, let me just give you a couple quick goals for what I'll be talking about today. So the first thing I want to talk about is the knowledge to action cycle. Some of you might be familiar with this. This is work by Graham et al. That I'll be talking a little bit about, but it really has been a guiding principle in the work that we've done through this accelerated transition to a virtual program for the Comfortability. So I want to really ground you in the theoretical and then compare and contrast that a little bit to what actually happened when we applied this to the work that we're doing. I'm going to introduce you all to the Comfortability Program if you're not familiar with it, and talk a little bit about sort of what the program was pre-COVID, and then how we've been able to transition to a post-COVID or interim COVID, I should say, treatment plan that has been working quite well. And then lastly, I really want to share sort of our boots on the ground kind of experience, like what we've learned through this process a little bit, the iterative nature of the work that we've done, because for sure, when you have to pivot, you don't always get things right the first time. So I'll just share with you a little bit about what that experience was like for us and how we got smarter and sturdier as we went along and we continue to grow. Okay, so first of all, let me just make sure we're clear on a few definitions here. So whoops, that's not the right slide. There we go. What is knowledge mobilization? So the basic definition for knowledge mobilization, think about this as just how do you get knowledge out into the world, like good scientific knowledge that you want to spread. So the basic definition is sort of the activities and materials that are created that help your research to be used. And that's really what I'm quite passionate about in my work. We've got so much good research. How do we get it out to the people that need it to make important changes in their lives? That's the basic definition, but here's the formal definition. It's an umbrella term and encompasses a wide range of activities relating to the production and use of research results, including knowledge synthesis, dissemination, transfer, exchange, and co-creation or co-production by researchers and knowledge users. And this is really important because this umbrella term, so knowledge mobilization, doesn't just mean innovating or creating new resources, but it's the whole package about how do we get these resources up and out so that people can make use of them. And certainly in the times of COVID-19, mobilizing what we know and getting it to people that need it was critical and remains critical. And of course, even outside, looking beyond sort of what's going on with COVID right now, there's a big research to practice gap. We know that this exists. And these are, stats that you might be familiar with. On average, it takes 17 years for evidence-based research to be implemented in clinical care. And then less than 15% of evidence-based research makes it into clinical practice, which means that despite 20 years of research evidence, psychological strategies for pain are vastly underutilized. And this is my wheelhouse. I'm very interested in how do we take what we know from psychology, and there's so many reasons why psychological research in particular, I think is underutilized. There's lots of different barriers. One of those areas is provider level barriers. Providers are overburdened with the work that they have. They've got limited time for program development, and many providers in pain management, many psychological providers in pain management are working in silos. So they might not have colleagues that are there supporting the work that they're doing. Some of the major academic medical centers do, but the vast majority of people who are practicing, there might be only one or a part-time person working in this area, which makes things really difficult. But then there are also institutional level barriers. So there's really complex and inflexible healthcare systems, which makes it hard to put new research into practice. Something that could be just a small change that could have a big impact can feel Herculean. It's really, really hard to get things going. And we've all got outmoded procedures for systematically implementing change. There's no highway for doing this. And so the work can be very slow and very tedious. And then there are also patient level barriers. So patients have limited or no access to services. In psychology, mental health stigma remains a significant barrier, especially when you're talking about physical manifestation of pain. So patients often think of pain as a physical problem. Understanding sort of where psychology fits into that treatment picture can be very confusing and hard for patients. And then also, I think at the patient level, but I'll say sometimes at the provider level too, in multidisciplinary clinics, there can be a lack of knowledge about the efficacy. Yeah, it could be helpful, but they're not quite sure exactly how or why. And so these are really sort of big barriers to overcome, and they have nothing to do with COVID, but you overlay COVID on top of that, and it becomes even more challenging and complex. So in the area of knowledge translation, we think about sort of this process, how stakeholders and change agents work together to promote quality and effectiveness of healthcare-based resources. And in this area, we've got stakeholders or change agents. You've got the evidence producers, who are the scientists and the researchers, and then the evidence consumers, that are the practitioners and the policymakers and the patients and families and the public. And in this knowledge translation piece of things, trying to get things up and out, we have to think about sort of all of those. And this is, a good place to sort of introduce what the comfortability program is, because it is at its basic level, it is a program designed to teach kids and parents proven skills to manage chronic or persistent pain. And that is sort of the crux of what we are doing. It's a brief CBT-based intervention, but it also extends quite a bit beyond that, because what we're trying to do here, a few CAP basics for you. Our mission is to teach kids and their parents evidence-based psychological tools to manage chronic or recurrent pain. Our goals are to engage families, to educate them, so with all of the pain neuroscience education, to support them, and to empower them to make changes in their own habits and behaviors that will result in better function and less pain, ultimately. And our vision is reduced disability and comorbidity associated with persistent pediatric pain through enhanced access to care, improved parent and child self-efficacy, and connection to science-backed resources. Real briefly, how it works, our workshops are brief CBT-based interventions. They are delivered in a group format. They initially were only delivered as a one-day intensive group-based in-person intervention, but now we have a virtual intervention as well, which is what I'm going to be introducing to you. And there are separate parts of the program for kids and parents. Each group gets a minimum of 6 hours within the workshop design. So parents and kids each. And the workshops are run by healthcare professionals who have been trained to run the comfortability program. Just a few quick stats on our program here. It's been running continuously for 11 years. The network, and when I say running continuously, that was at Boston Children's Hospital, where I started the program, and we have run continuously since its inception 11 years ago. The network piece of it, where we tapped into other children's hospitals and brought on other groups to run the program, started 6 years ago. And to date, we have 24 sites in the US and Canada and Australia. We've trained over 150 providers and treated over 5,000 patients. Our focus has really been on slow and steady growth with careful alignment to the mission, a focus on feedback with patients and partners, and iterative development. So over time, changing based on the needs and the feedback that we've had. I'm going to just say really quickly about sort of the work that we do in the Academic Medical Center, because in knowledge translation and translational science, you can create a really good innovation. You can have good training materials, and you can train up sites and for individual providers to run the program. But really what we're doing is embedding this program mostly in academic medical centers. And so we have to really tap into the whole ecosystem here. We have to help new sites understand, how do they sustain a program? How do they fund a program? How do they get research going on the program? So there's quite a lot involved when we think about all of those stakeholders across the systems here. And the comfortability program, one of the things that we really want to do is support sites in doing all of that good work. This is the knowledge to action cycle from Graham et al. And I'm just going to really quickly run you through these steps here. It basically starts with identifying the problem. So in our case, it's real hard for families to access targeted psychological intervention for pediatric pain. Then adapt it to the local setting, which is what we did at Boston Children's. Look at the barriers, what's working well, what's not working well, tailoring the intervention, monitoring and researching the knowledge use, evaluating the outcomes, and then sustaining the knowledge use. And those things all inform the work in, oops, excuse me, one second, in the middle here, the knowledge inquiry, the synthesis, and the tools and the products that help the information get up and out. That's the theoretical model. This is the real model. When we sort of looked at what we were doing, at the comfortability, this is sort of how it boiled down to us. And I really break it into three different sections here: the generation phase, the dissemination phase, and the maintain and innovate phase in the work that we're doing. Within this first section, we're identifying, we did the same thing, identifying the gaps in knowledge, generate the information, evaluate outcomes. In the dissemination phase, we're looking at testing it, expanding our clinical partnerships, monitoring and sustaining the use. And all of that leads to the CAP assets, which are the patient-facing workbooks and materials, the comfort kits, the training materials, all of that. Okay, that's the work we were doing pre-COVID and why we were doing it. We really felt like we had developed an excellent program. We had gotten to a bunch of clinical partners, and then COVID hit, and we were responsible not only for the services at Boston Children's, where we'd been running the program, but throughout our network. Everyone's like, now what do we do? And so we jumped to action. At the time that COVID hit, we had 20 children's hospitals that were part of our network all over, East Coast, West Coast, and internationally. We also had some organizational partnerships, and these were really key in helping us to mobilize to transition to a virtual program. We sat down when COVID hit and we said, what are the guiding principles here? What do we need to be able to hang our hat on if we're going to pivot here? And the first thing that we wanted to really nail was fidelity. We had great research on the in-person workshops we were doing, and this was really important to the families that were using the program, but also to all of our partner sites. So fidelity, making sure that a new program also could have strong, sturdy outcomes, was very important. We also knew it needed to be flexible and work for different institutions and different providers, and it had to be sustainable. So we looked at this as an opportunity rather than a challenge to create something that would have long-lasting impact and maybe be an alternate means of delivering the content. So here's our quick case study. In March of 2020 was our last in-person workshop pre-COVID. By April, 1 month later, we piloted a virtual version of the program. We just said, we took a month, we just real quickly put something together, and we said, let's try it, because we had patients that were so in need of service. We were sort of at this desperate place where something was better than nothing. So we put something together, we piloted it, and then we shared the content with Stanford. And in May, they piloted it, and then we revamped from feedback. We did a new second pilot with new content and new materials in May, and then we shared that with Alberta Children's Hospital. And in June, they did a pilot and tested it, and we got feedback from their site as well. And then we revamped and repiloted. In June of 2020, we ran our third one. And then in July 2020, from all 6 of those pilots, we collected all of the information and we developed our virtual comfortability materials. And then by October 2020, we were starting to train new sites on how to administer this content. We really mapped, I should say, the work that we were doing to the structured knowledge translation process that had worked so well for the development of the original CAP. We got an internal grant from Boston Children's for an accelerated transition. So we had a lot of hospital-based support to help us get through these various stages. And I'll just walk you through this really quickly. Sorry, let me go back 1 second to the generation phase here. Here we are at stage 1. We needed a feasible alternative to the in-person workshop. So we led an adapted version of it. We piloted it, we shared it, and that was all the sort of generation phase. What was different in this process as compared to our original process was that we really leaned on our partner sites. We were stronger for the fact that we could share materials with them and get feedback. And that helped us to do an accelerated translation. We couldn't have run that many pilots ourselves. So by sharing the content and using our partner sites in the generation phase, we were able to rapidly come up with an excellent or a pretty sturdy product. And then we went to the dissemination phase where many of our other partner sites were eager to get the materials so that they could start doing that as well. So we started to onboard partner sites, and we also launched a multi-site study so that we could much more systematically test the work that we were doing. And then the other thing we did was launch a training portal to make it easier to onboard more sites virtually. We got lots of feedback from our partner sites. Having a formalized program that was ready to roll was a huge asset for everybody that was scrambling to provide service. Lots of improved accessibility. Many more families could be served. They found that there was good social support. They liked the separate parent component. So we had a lot of positive feedback, but we also got some really good critical feedback for how to improve things. And that wasn't, we think of that as an asset in the work that we're doing. For example, some of the content feedback, since we were doing it virtually, they wanted more, our partner sites asked for more interactive videos, more flyers and handouts and materials to sort of advertise that we were doing this. And then additional support to make it easier to train new people, to communicate about the program, and to communicate between the hub and the partner sites. So what we ultimately ended up with in terms of this transition was the adolescent program, which exists in 4 virtual sessions. They're 90 minutes each. And they use the same workbook, but there's a slide deck that goes with them. And so they can be interactive and deployed through Zoom. And then there's a parent program as well. There are 2 sessions. Each of the parent sessions are 3 hours long. And again, we are using the same materials, but it has a very interactive deployment so that families are engaged deeply with the work that you're doing. And then we built a professional training platform through Open Pediatrics. And this has really allowed us to onboard new providers, even though we can no longer travel to do the trainings and things like that. We're really set up to do it well through Open Pediatrics. So I'm going to pause there. I know I'm out of time. And these are some references. If anybody has questions about the program or wants to read about the research on the program, we have that all freely posted on our website, thecomfortability.com. Also, you can feel free to reach out to me. I'm happy to share any information about what we've, additional information about how we've pivoted or the work that we're doing. So thank you very much for your time and attention. It's been a pleasure to talk with you today.
That was such an awesome session. I want to thank our 4 speakers. We do have some questions, but I want to start off as being the moderator. I get the privilege of maybe asking 1 or 2 first questions. You guys gave some great examples of how you've pivoted so quickly to virtual care and the positive impact you've had on people's lives who are living with chronic pain. Because we know in the pandemic, loneliness is one of the big things everyone's feeling, especially with chronic pain. And we have lots of data showing lots of people having new onset pains. I want maybe each of you to talk about what were some of the biggest challenges. And I know Romy talked about sustainability, but maybe you could outline some of those challenges and how you overcame them. Maybe we'll start with Jenny.
Sorry, Jen, did you just, sorry, you kind of cut out at the end.
Yeah, sorry, my internet was a little bit unstable. I just wanted to ask, what were some of the biggest challenges that you had in pivoting to virtual care, and how did you overcome them?
Do you want me to start?
Yeah, why don't you start, Jen, and then Jenny?
Sure. The challenges were, I guess, just the big one was we weren't sure if people had access to the technology and if they were comfortable using the technology. People had real concerns over privacy and confidentiality. We were not sure. We knew that one of the benefits of some of the in-person peer-led or even facilitated groups was, more than the knowledge that we were sharing. It was the people's connections with each other that always came out in the evaluation data. That was the number one benefit for them. So we weren't sure if we could replicate any of those things in the online environment, right? And so I guess we had some mitigating strategies. For example, we worked with people to overcome to make sure they knew how to use the tech. We had a policy around sharing participants' information with each other because they did request to connect. And we tried to encourage that type of thing. So, I don't know that everybody was, I don't know if it was the exact same as if it was in person, but given the circumstances, we kind of did what we could. And for some people, it worked out better because they didn't have to travel and they were in the comfort of their own home. And then for some people, it wasn't as good. I think it was a little bit variable, but that's what we did. Jenny, over to you.
Oops. I can't necessarily speak at the program level, but only to the experiences that I had when we had online programs. The interesting thing about the challenges with tech, because we were getting a number of people who didn't know anything about Zoom. And so they were actually recruiting family members. So, I mean, pain is a family issue, right? And so it was really touching to see how our program attendees would recruit their families in order to help them access these programs. Yeah, in terms, I mean, in terms of the attendance of our groups, I know that there was a certain amount of continuity where we would see attendees attend who were in the in-person group following us to the online groups, and since we've been on a break for summer, we're also getting feedback of when are the groups going to happen. So I hope that answers a little bit of your question, Jen. Yeah, so thank you.
Rachel, maybe, Romy, it looks like she's ready.
Yeah, so essentially, our patients had the same problem that I've had this evening. So the cell phone coverage wasn't working. So I had to run around and finally hook onto somebody's Wi-Fi who's very kindly lent it to me so that I can join in. So that was a very real issue for patients. And intermittent connectivity. So there's nothing worse than being in the middle of something and then it goes. And we often had that, and then had to coach people through, okay, so drop out, drop back in, see how you go. And yes, sometimes family could help, but sometimes there was nobody to help. So that was a real challenge for people. And then similar to Jenny, of just teaching people how to use WhatsApp, which was the environment that we used, and what is a video call, and can you mute your microphone, please? Yeah, that down there, can you mute your microphone, please, because we can hear your dogs barking and your children playing, and we can't hear what the other person's saying. So those were real practical challenges.
Thanks. Rachel, I don't know if you want to add anything else?
I'll just real quickly say that, for us, I think one of the first big hurdles was just the infrastructure, making sure that we had privacy and compliance with the interface that we were using. We couldn't get insurance coverage because there was no mechanism for covering group-based telehealth kinds of services where we are. And so just working through some of those major hurdles at the beginning from the infrastructure piece of things, and then helping our partner sites to jump those hurdles as well, because each healthcare system had their own specific hurdles about using new technology and getting services paid for and things like that as well. That was one big hurdle. And I think the other was from the patient perspective. One was just how do we get the materials? We had workbooks that went along with the program. So how do we get those to our patients? Zoom fatigue was a big issue for the kids and parents that we were working with. Everybody's doing office work and schoolwork online. So then to add more into that. So we had to sort of, really work around those issues as well. And then I think the privacy and confidentiality when you're working with teens and they're at home and there could be many family members in a very small space, giving them, trying to figure out how can you get some privacy that you can talk about these issues and feel, safe and secure in your home environment doing it. So those were, I think, the big issues for us.
Yeah, that's great. I think Jennifer Kirkwood had that question about were there challenges in getting supplies to patients and families. And I think Romy and Rachel, you nicely addressed those. I think one thing that's come through for all of your presentations is the importance of involving people with the lived experience. And it's so important to do that. And the train is already gone. Like, we just have to be there and involve patients and families. So can you talk about some of the benefits and challenges of involving patients and families with these pivots to virtual care applications that each of you have created? Rachel, do you want to go just because you're still up on the screen?
Oh, sure, happy to. So, our peer advisory board are all patients with lived experience, and the parents are, some of them have their own lived experience with pain, and some of them are just parenting kids, teens, young adults who are going through this experience as well. And it was, at the beginning when we were sort of in this formative stage, when we were looking at sort of how are we going to do this? How do we balance sort of how much screen time, especially for all the kids, that we work with that have headaches? We had a lot of input, and we really were working to have multiple conversations on multiple fronts. How do we sort of integrate the feedback from the patients and the parents who had great ideas for us with where our constrictions were? We had some real limitations about how we could operate, what was feasible, and how we could exchange information. And I think sort of trying to find that sweet spot between what good ideas were coming from our board and where we were feeling a little bit strapped in terms of what we were allowed to do took some work, but I do feel, and as I said, we really work on this idea that the program and the materials are iterative. So we go through changes from time to time. So we already have a whole list, of sort of updates and things that we'll integrate in our next sort of refresh of the program as well. So I think just staying open and having those conversations is really critical.
Romy, did you want to add anything to that?
Yeah, so this was actually the first time that we got our expert patients actively involved. So we've had patients who said they'd like to contribute, but previously they've been quite hesitant and nervous about it. And in this situation, we just went to them and said, we desperately need your help. There are people, who need to hear from you in this situation. And yeah, they were amazing in terms of taking the initiative and saying, yeah, okay, so I'm going to record a video and then I'll record some podcasts so that it doesn't use so much data. So they were very aware of, the challenges that the patients were going to be facing, and engaged just amazingly on that. Yeah, so it was kind of, for all of us, the patients, our expert patients, and for us, just a leap of faith. Let's just do this. Let's just get on with it. And as Rachel has said, it's a work in progress. We're every time we're running it, we're morphing it, we're changing it, we're learning as we go. So it's the ultimate exercise of psychological flexibility.
Thanks, Romy. So I'm just going to, before we wrap up, just maybe turn it to Jenny to give us one final comment as our patient partner on this panel.
Oh, no pressure, but thanks. I think what it comes down to is a comment that Jen made in her introduction was, as a daughter and as a sister of a person living with pain, this is the impact of the work that I do. This is what meaning this work has for me. And the majority, not just the peer facilitators, but there are many people on the pain team itself, Pain BC team itself, who also live with or have lived experiences with pain. And so and I'm sure all of us got into pain because of our own experiences of living with pain and what this work means to us. So I there is something to be said about what moves us and what keeps us alive in this work. So that's it. Thank
Thanks,
you.
Jenny. That's a great way to end this. So I just want to truly thank each of the speakers for being part of this panel and for everyone that joined from around the world. And please make sure you enjoy the rest of the sessions this afternoon and on Friday. So thank you, everyone. Have a great day.
Thanks so much to IASP and GAPA Pain and Pain BC and all of you. Thank you.
Absolutely. Thank you, everyone. A pleasure to be here.
Thanks, everybody.
Thanks so much.